Hello, everybody. Welcome to our first Ask the Expert of the year. If you're watching this live now, hello. Say hi back and just type any questions you have in the comments. I'm Martine Wormsley. I've had PSC for 15 years, and I'm delighted to be joined by Dr. Deepak Joshi, who's a consultant hepatologist at King's College in London. Welcome, Dr. Joshi. Dr. Joshi is a liver specialist in the busiest transplant centre in the UK, and he looks after PSC patients before and after transplant. And he specialises in, correct me if I'm wrong with any of this, but specialises in endoscopy, so things like ERCP, particularly in the children, and looking after young people who've got liver disease as their care goes from paediatric services to adult services. So this is a really good opportunity for anyone out there to ask questions about PSC, whatever age you are. No question is a stupid or dumb one. If you're thinking it, probably someone else is as well, so please ask. So Dr. Joshi, it's really great to have you with us today, and thank you for joining us. Over to you.
Thank you, Martine, and thank you to the PSC Sport for asking me to do this session today. I'm based at King's down in South London. So I've got about 10 slides or so, not many, and I just thought we'd do a quick revision of anatomy. I would talk to you a little bit about the PSC service at King's and how myself and colleagues deliver that, starting in paediatrics, going to the young adult service, and then obviously into the full adult service. And then I'll mention a little bit about the role of ERCP, which it's something I do deliver. So I think a lot of this everybody will know, but with our liver, we have two lobes. The right lobe is bigger, and within the liver are the bile ducts. We have the main bile duct, which is the common bile duct. We have a gallbladder, which comes off, and then we go off into the right and to the left-hand side. And really, it's important to know where PSC affects the bile ducts. It's not just sort of the bile ducts. It can be the bile ducts within the liver. It can be the bile duct outside of the liver. It can be one side. It can be both sides. So it's really important, certainly from my perspective, when I'm performing ERCPs or looking after patients, to understand where their disease is. And if you do enough ERCP, you start seeing the bile ducts and the biliary tree everywhere you go. This is, I think, apple and elderflower taken from Marks and Spencer's, and I think this sort of illustrates it beautifully. You've got the common bile duct, the gallbladder, and the bile ducts within the liver, and the buds sort of represent the liver cells. So if you do it enough, you see it everywhere. So it's important to also remember where the bile ducts, the liver sits in relation to the other organs within the abdomen. And this is me trying to be very clever and just sort of showing you where things roughly sit. So these are your rib cage, and then obviously that's your belly button. But you can see everything is quite compact. You have your pancreas very nearby. You have your main blood vessel going into the liver, which is your portal vein, which comes off your spleen, and the sort of the veins which come off your bowel, and then sitting over here is your stomach. So everything is very nearby, and we should always remember that when people describe pain in the right upper quadrant, there can be other organs as well, apart from the liver or the bile ducts. So a little bit about our service at King's. Like Martin said, we do look after sort of paediatric patients, and then they come into the young adult service, and I help support that service. So, and that starts at 16 to 25. And then at 25, those patients can either be allocated into my adult clinic or other clinics as well. But if we're talking about PSC within the adult service specifically, there is a dedicated clinic. It's Monday morning. There's a clinical fellow and myself, and we're hoping to expand that because the numbers have just got bigger and bigger. And in this clinic, what we try and do, we try and offer, a sort of full holistic approach. We fibroscan patients to determine the level of scarring or fibrosis. We also screen for mental health concerns as well. So one of the things we're able to do at King's is we have a very strong psychology and psychiatry department, and what's embedded within the service is a electronic questionnaire where we can screen for anxiety, depression, sort of any kind of substance misuse, and we started to incorporate that to all our patients that come to the PSC clinic. And we're just looking at sort of a year's worth of data, people online. Some people may have come to the clinic, may have filled out this questionnaire. We can adapt it and then hopefully see what our results are. I think as well as providing the sort of generic clinical care, we also discuss clinical trials, and we currently have sort of 3 studies that are running at King's, and we will try and offer a trial if suitable to all patients, or at least consider them. And then in some patients, we do need to discuss the role of liver transplantation. And again, that's something we do at King's. We do plenty of transplants, and we can sort of facilitate the referral. We definitely have a multidisciplinary team approach. It's not just myself and my fellow, it's all the rest of the people that are involved. So that's radiologists who help us interpret scans. We have histopathologists who look at biopsies, tissue that we take either as liver biopsies or at the time of ERCP. And we have surgical colleagues as well who are very important, whether it's transplant or non-transplant. And then there is the role of endoscopy as well, in particular ERCP. This is some of the team. Actually, I have to say most people have left. I think it's just Andy and myself. Andy's one of our transplant anaesthetists. He's still there. Everybody else has moved on to maybe bigger and better things. But all our ERCP is under general anaesthetic, and that's whether you're a baby or you're nearing your century. And we perform it in endoscopy. And I think we pride ourselves on the service that we provide because we have dedicated anaesthetists, ERCPs, and endoscopy nurses as well. And I think because it's under general anaesthetic, it's the most comfortable for patients. It's certainly the most comfortable for me because some of these ERCPs can be quite tricky. So just sort of a quick overview of ERCP. I think any patient with PSC, everyone requires antibiotics, and this is taken from the European recommendations for endoscopy in PSC. So if you're having a ERCP and you have PSC, you should have antibiotics, and feel free to challenge or question your care provider if they're not doing so. And these are some of the common indications. If we look at sort of these two, usually it's if you have a dominant stricture, which is a narrowing in the bile duct. It could be due to gallstones, which may be within the bile duct, whether it's outside or within the liver. And then very rarely we do this procedure called a nasobiliary drain when there's sort of severe itch, but it's in smaller font because it is very, very rare. Not all centers really do that. And, I'm sure when you've had an ERCP, it's always good to see the pictures as well. And this is a patient you can see who has sort of a widened or dilated bile duct here on the left-hand side, and then features of PSC. Certainly when patients come to clinic with come to see me, I will always show them their MRI scan or their ERCP pictures, because I think the pictures just really explain it far better than any sort of description or diagram from me. I think the other aspect, and I'll play this video very shortly, is we're using cholangioscopy, which is an endoscopy of the bile duct more and more. And the reason being is when you have strictures, if I go back a slide, you can clearly see it's narrowed here, but if you can actually see the stricture as directly with the scope, it's very different to looking at it with X-ray. And that's what ERCP is. We inject contrast, you fill the bile ducts, and then you sort of interpret those areas. But it's a 2D image as opposed to cholangioscopy, which is an actual endoscopy of the bile duct. So this is the major papilla that it's going up the bile duct, and this is what the inside of the bile duct looks like in this patient with PSC. So this is the guide wire we're following up, and this is the inside of the bile duct. There's sort of these little slight pockets here, which we can see. Sometimes they're called diverticuli, but you can see actually the lining of the bile duct here looks very smooth. It doesn't look particularly inflamed. It looks sort of normal, if you like. So, this is very reassuring. And, I think cholangioscopy has really changed how we, can view the bile ducts, because before it was limited due to the fact that the bile ducts are very small. We're talking sometimes, 7 to 8 millimeters, maybe 10 millimeters in diameter, and trying to insert a scope can be very tricky. But as is the way with technology and sort of digital technology, we are now able to do this, and we're doing this more and more to look at strictures, these narrowings in the bile duct, and then be able to sample them and take direct sort of biopsies from it. So I'm going to stop there. I think there's sort of lots of things which may sort of stimulate discussion, but I'm happy to take questions, and we can take it from there.
Thank you, Dr. Joshi. When we were just looking at that video, that tube or that bile duct, was that the equivalent of the stem of your Marks and Spencer's
yes,
flower?
Absolutely. So so that's the main bile duct. As we go up, you can go up into the bile ducts within the liver, but again, you're limited by size. The sort of diameter of the scope that we can place into the bile duct is about, I'd say, sort of 5 millimeters. So as long as it will allow us to, go up the bile duct, then we will try and insert it. And the views are very sort of interesting. There's lots of different things you can see, whether it's stones or sort of inflammatory tissue or sort of ulceration. And we're trying to move to a point where we can look at something and say, well, actually, this is PSC as opposed to PSC plus something sinister or not.
It's the holy grail, isn't it? We wonder what's going on inside all our little strictures.
Exactly.
But it's good that the technology is moving on. All right, let's have a look at these questions then. So the first one, hi, I was wondering whether corticosteroids can be effective for PSC in the absence of other autoimmune conditions. And she said, I'm sorry if it's unrelated to the presentation, but that doesn't matter.
No, it doesn't. I mean, if you want me to present on PSC, we'll be here all day. There is no role for steroids in PSC. I think, if you're being offered steroids for PSC, you do really need to question the diagnosis and ask whether do you have an overlap. So sometimes there can be conditions where you have sort of an autoimmune hepatitis. So that's inflammation of your liver cells where the body's attacking itself. And you might have sort of changes within your bile duct as well. Now, in younger patients, it can be offered if there is both of those things. And younger patients, I'm talking almost about pediatrics. But in adults, we wouldn't do it unless we thought there was an overlap condition or a condition outside of PSC alone, because steroids have lots of side effects and you've got to be careful. Even with a short, sharp course, it can cause changes in your blood sugars, can make you put weight on, affect your blood pressure.
Sometimes get given to us for IBD as well, don't they?
Yeah, absolutely. I think, again, if it's for other things, then that's fine. But for PSC alone, I think you need to make really sure that the diagnosis is correct then.
Yeah, good. Thank you. Okay, next question. Another really good one. Does stress impact disease progression?
I think the sort of scientific answer sometimes would be no, but we all know that stress affects us in different ways on a daily basis. And, the last 2 years have been a great example of how stressful life has been, from not being able to go out and meet family, meet friends, do all the things which, we've enjoyed doing. So there must be some element where it affects, the disease. But I think, like I said, at a scientific level, probably not. But, if you feel stressed, you're more likely to be more run down. You may be more susceptible to sort of other sort of, viruses, and, things just aren't great. So, and psychologically, it must impact on the individuals. So, trying to avoid stress is the holy grail as well, I think, for everyone.
Yeah, we certainly have a lot of conversations like this on our Facebook group where stress does make people feel worse, and they definitely see more symptoms for their autoimmune conditions, and we all feel like we can see a little bit of a link. So I'd like to see some research done on that actually one day. That'll be very interesting. But like you said, it could be just somehow connected, like, you know, maybe more susceptible to other things going on. Okay, why does this comes up a lot as well. This is a good one. Why do some hospitals use general anaesthetic and some don't for ERCP?
Okay, so I'll tell you how things evolved at King's. So I think probably about, must be going on 20, 25 years ago, you know, at King's, a decision was made that the safest way to perform ERCP in all patients would be under general anaesthetic. And there must have been, you know, a number of either complaints potentially, or, you know, cases where the case had to stop early because, you know, sometimes sedation is it's just not enough. And if you're anxious, it doesn't matter how much, you know, I give you, you're going to be awake. And I always sort of liken giving sedation to a patient undergoing endoscopy to trying to put a baby to sleep. You give the sedation, you look at the patient, a bit like how you look at your baby, you think, oh, no, please go to sleep, please go to sleep. And you keep looking at them and their eyes are wide open and they keep looking back at you and you're like, oh, please just go to sleep. And then there's a flicker of the eyes and then they're awake again. So I think in some people sedation just doesn't work because it just heightens the feelings that they already have. So ERCP in PSC patients is a little bit more tricky because they're you know, if you're going into work on strictures, you need very fine guide wires, you need to take your time. You know, you could be talking about a good hour of trying to sort of treat the areas that you want to treat. And certainly if you add in cholangioscopy, there's an added piece of time because you have to sort of set the equipment up, you introduce it, then you have to take it out. So I just think it's better for the patient. It's better for the staff, the nursing staff, because they're not anxious. You have an anaesthetist who's looking after the airway, they're looking after the blood pressure. They can concentrate on that. And then that allows me to concentrate on what I'm there to do, which is obviously do the endoscopy and treat sort of the strictures. I think if you bring it down to the basic level, there is a cost implication of having general anaesthetic.
Yeah.
And certain trusts maybe can't afford, you know, to have an anaesthetist, sort of anaesthetic assessment, you know, a sort of assistant. So there is that aspect, but at King's, like I said, it's always under GA.
Yeah, I was going to ask if is this kind of a trust-wide decision, because there are hospitals that really don't let you. So you couldn't go to your hospital and insist on it then? You're bound by their rules, or could you?
Well, you are, but you know, I think so. For example, ERCP in patients with PSC should only be really be done by big centres who have the experience because of the sort of the more technical, you know, technical difficulty involved with the ERCPs. And if you look at the European and British guidelines for the management of PSC, they all say that, you know, it should be undertaken after a multidisciplinary team discussion to agree what the role of the ERCP is, because ERCP will be therapeutic, and then you know, it should be undertaken by experienced operators. So if you're having an ERCP and they're a small centre and you have PSC, you really have to sort of question the team. You know, do they feel that they are the best people to do? We're all linked into sort of referral networks, but I suppose you can't demand anything, but you can make the point of saying, I think it would be better under either general anaesthetic or propofol, which is the anaesthetic drug, but you know, it's heavy sedation or deep sedation, as we call it.
So try and put a really good case together. Would you ever have a patient just be referred to King's, for example, just for the endoscopy and then back to their hospital? Could you do that?
Yeah, absolutely. So King's, we sort of service and sort of look after the sort of southeast of England, so the Kent area. You know, we can do the ERCPs, but then, usually what we say to our referrers is it's shared care. So they might see us once a year where we can sort of keep a close eye on things. And then the 6 months in between, they see their local team. And then that way they get access to clinical trials or any other sort of, benefits that we can provide, really.
Yeah, that's a good idea. And it's good to know that you can do that. Do you do that for diagnoses as well? So we see quite a lot of people, well, we have done recently at the moment, where the doctors are not quite sure whether the person has got PSC or not. And what they're doing is they're just saying, oh, well, we'll do another scan. One of them was, we'll do another scan, an ultrasound scan in 3 months and then decide. And in my mind, I'm thinking, no, you need to go to a specialist. Could that doctor refer to you and say, could you check this MRI scan and tell me if it's PSC or not?
Yeah, I mean, absolutely. I mean, we get lots of referrals for review of imaging. Again, like I sort of showed in my slides, I rely heavily on my radiology colleagues, some of whom have been doing this far longer than I have. And it's their experience, their sort of previous sort of interpretations of scans. And yeah, we will support any referring hospital who would like either a review of imaging, review of a biopsy, or a review of the patient as well. So that's easily done. And I think, how we can deliver that, it's been made a little bit easier with sort of COVID and the introduction of video consultations as well. So sometimes patients don't have to travel. And we can do video consults, we can do telephone consults as well, as long as the referring team send through all of their sort of clinical information. It's easily done. And I find we're doing maybe 2 to 3 cases every couple of weeks where we're reviewing the patient and then say, look, this is what we recommend back to you, or if you want me to see the patient face to face, then I'm happy to do so.
That's really good. And that's a win-win for everybody, isn't it? It's a win-win-win for everyone. Thank you. Okay, next question. If the stents can't be placed because the ducts are too narrow, are there other procedures that could be done?
Yeah, that's a very good question. So we have different sized stents. The smallest one is, so we go in Frenches. So it starts at 5 French, which is about 2 millimeters in diameter. So we're talking about tiny little things. And then we go up to the metal stents, which are about 1 centimeter in diameter. So they go all the way up. So there are some cases when we can't get through. And the way we try and get through a stricture is we pass a guide wire through, and then we would stretch it very gently and then place a stent. Now, as a group of sort of healthcare professionals, the sort of tendency now is to dilate as opposed to stent, because there's some good data to suggest that it's maybe associated with less side effects. But if we do fail, then again, you go back to your radiology colleagues. You can sometimes you have to sort of puncture the bile ducts from the outside, and then sort of place to drain and sort of treat the strictures that way. I have to say, by and large, that's quite rare these days. But if the if we need to do it, then the availability is there if you've got good radiology colleagues.
Wow. So would you have to sew it up as well? So you'd like go in?
Yeah.
So
so they place it through the abdominal wall. They place the drain, and then it sort of would go through. But you are left with an external drain. So like I said, it's very rare in PSC to do it, because if you can't do it endoscopically, you really need to make sure that the external route is suitable, because sometimes people have very severe stricturing which we can't get through, and then if they keep getting cholangitis or pain, or the itch is really bad, then obviously you need to think about the next steps being potentially a transplant.
Thank you. Change of tack now. Is there a specific level of liver damage or risk factors that are not advisable for planning pregnancy? And what would you advise for planning pregnancy?
That's a great question. So a bit of advertisement. So we're putting together some European data on pregnancy in PSC. So there's a group called the International PSC Group, which I'm sure you're aware of, Martin. But one of my former fellows, who is sort of just finishing up, we've contacted other centres in Europe just to see what the experience of pregnancy in PSC is. So it'll be real life data. We're hoping to have an abstract maybe later on this summer, which we will obviously submit. So I think that would be interesting. But I think answering the question, sometimes if you have very advanced liver disease, if you have sort of cirrhosis, you're jaundiced, the likelihood of becoming pregnant sometimes is quite low. Okay, the way we would sort of discuss this with an individual who was wanting to become pregnant is we would sort of review their sort of blood tests, their sort of severity of their disease, and if they would wanted to become pregnant, then we would support them. I don't think there's ever a time when it can be the individual can be too unwell, but if they do have cirrhosis, then they would need an endoscopy in their second trimester, because if they have varices, sometimes they can get bigger, and in pregnancy in general, you get an increased blood volume in the second trimester. So we would screen for varices, and then again, we're very lucky at King's. We have a joint liver obstetric clinic run by Professor Michael Heenan, who some on the call might know or met at King's. And we manage these patients with a very skilled obstetric team who are used to looking after women with sort of complex diseases, not just liver, but other complex diseases. And then we have the sort of expertise of Professor Heenan, and when he's away, it's me. So yeah, we do get the experience.
That's fantastic. So if somebody is planning to get pregnant, they should let their PSC doctor know, and they would work, well, if they weren't at King's, they were at a different hospital, they would work with their obstetric consultant then as well, presumably.
Yeah, and again, if their obstetric or gastro or liver team weren't quite happy, then they can be referred to the joint liver obstetric clinic at King's.
Great, thank you. We'll have to put some links up, I think, for these things. Okay, next question. Why is it that transplant is an option for PSC patients up to the point cholangiocarcinoma is diagnosed? This is a long question. Transplant is an option in some European countries and the USA, but doesn't seem to be viable yet in the UK. Although in 2020, a group of specialists have indicated that a trial may be possible. Are there any developments with this? I know a little bit about this as well, actually.
Okay.
You go first. You know more.
I'll do my bit, and then you can correct me. But I think we all worry about cholangiocarcinoma in PSC, and that's one of our concerns when you look after patients at whatever age they are. And I have to say, when I've had to give that sort of news to people, it's devastating. So the problem with cholangiocarcinoma after a transplant is it comes back. We give immunosuppression, and basically, although the cancer may be just found in the liver, when the liver comes out, there's usually some spread elsewhere, and then it comes back rapidly, aggressively, and treatment options are very, very limited. Now, the individual who asked the question has made a very good point. In certain centres in Europe, they will consider it, depending where the cancer is. In the USA, there is a sort of Mayo downstaging protocol where they will potentially give chemotherapy, they will stage it, they'll do lots of things, but the outcomes, I would say they're not bad, but that's because at that centre, the Mayo Clinic, they're so rigorous in sort of managing those individuals. So coming to the UK, there is sort of a push trying to put forward a pilot study of looking at cholangiocarcinoma in patients for and being considered for transplantation. It's not quite got off the ground yet. And obviously, I think COVID has partly been to blame to that. But we're trying to expand the sort of options for transplant. And I think if we could, think about cholangiocarcinoma, then that'd be great for a number of patients with PSC.
Yeah, thank you. And that's what I was going to mention as well, that this group has been working on trying to get transplantation for cholangiocarcinoma and PSC off the ground. The last I heard, that they were talking about April, but maybe that's been pushed back because of COVID, but they were really trying to get it started.
Yeah, I think, lots of colleagues who think this is important. If the sort of allocation system for transplantation changed back in 2018, and we think we have we've sort of reduced the waiting list, so we're looking at other novel opportunities for transplantation, and cholangiocarcinoma may be one of them in a pilot study, and if we have good results, then obviously we take it out more and more.
And like the Mayo protocol, what happens in the UK would be very, very carefully selected patients, and not everybody, only be able to be some in certain circumstances. But if people do get diagnosed with a cholangiocarcinoma, when I've been talking to AMMF, who are a really good charity for people affected, and they say always get a second opinion when you're diagnosed with it, because when one doctor says there might not be treatments available, actually there may be others in specialist centres like the one in Manchester and in London, where Dr. Bridgewater, where they're doing special trials and things. So it's always worth getting a second opinion, and when that happens.
Yeah, I think overall cholangiocarcinoma is very rare as a cancer, and there are certain centres. I think it's the Christie in Manchester, and Dr. Bridgewater is based at UCLH. What they may have sort of options or sort of access to are certain clinical trials which may not be available locally. So I think that always makes sense. Oncology as a discipline, is very progressive, and they're always trialing new therapies. So definitely look for a sort of second option or second opinion. I would agree.
Yeah, thank you. Okay, next question. Is it normal to get trapped wind or gas following an ERCP procedure to insert a stent?
So most centres now, and again, you'd have to check with your local centre, we tend to use CO2 as the sort of insufflation sort of technique. So we used to be air, but CO2 is sort of less sort of distending, it's less uncomfortable, it sort of passes through much more quickly. But I can imagine, again, if you have a long procedure, you can probably feel quite bloated, but it shouldn't last for longer than sort of 12 to 24 hours, and one way or the other it will come out.
If you are worried after you've had a procedure, normally you get a number, don't you, with your discharge papers? Just call it.
Yeah, I think ERCP, if it's a tricky procedure, then that you'll always get good advice from your centre about who to contact, even on weekends. Most endoscopy units now run 7 days a week. So certainly at King's, if you've had a procedure in the preceding sort of 24, 48 hours, you can ring through to the endoscopy department, you can speak to the nurse in charge, and then you can be signposted, etc., if there's a concern.
Good, thank you. Okay, next question. A doctor told me that MRI had showed some disease progression in inverted commas, but couldn't elaborate as he wasn't my usual doctor. Does disease progression automatically mean a downward spiral in liver health?
So I think in PSC, we look at different parameters. So the parameters, when I review a patient, I will talk about their clinical symptoms, so itch, pain, episodes of cholangitis. So that's important for me to understand. The other aspects I will look at are their blood tests, and we look at the alkaline phosphatase, we look at the bilirubin, the jaundice level, and we look at the albumin. And again, these can be markers of disease progression. And I'd say the main one would be bilirubin. That's the main one which sort of gets me a bit concerned if that starts to go up or if the albumin starts to drop. Then we look at FibroScan, which is a marker of scarring. And then you look at the imaging. Now, on the imaging, again, you rely on your radiology colleagues to compare the current scan, and we're talking about MRI scans now. I don't think ultrasound would ever be good enough to tell you about disease progression, because it will tell you about obvious blockages or the size and shape of the liver or the spleen, or if there's fluid in the tummy, but it won't be able to tell you about the sort of intricate detail of the bile duct. So again, you need to compare that. So when somebody says to you, oh, there's progression, I think you need to ask in what way, because there's all these parameters, and some of them may be very stable and some of them may change. And again, sort of having your alkaline phosphatase go up a little bit may not be as concerning as if you're having cholangitis every couple of months or something. So you really have to ask that individual, what do you mean by progression, and in what way? Because it's not I think that's what makes PSC quite tricky to manage. Sometimes there's all these different parameters you need to look at in order to answer that question. You're on mute, Martin.
Sorry, it's going to happen, wasn't it?
Yeah.
I was just saying it just shows really that doctors need to be careful about the language that they use, because when you just throw around disease progression like that to someone with PSC, the PSC patients are quite knowledgeable and informed, and they will be worrying about all sorts of different things. So I think doctors just need to be a little bit more specific when, or be ready to discuss it and not just say something like that.
Yeah, I think, again, what I will try and, show individuals is their blood tests, FibroScan, recent one, previous one, if there's a previous one, show them their scans as well, and giving us an honest opinion and say, look, I am worried, or I am concerned, and this is what I think we should do. Or again, if I don't feel worried, I'll say, look, I'm very happy at the time being. Let's see how things go. So I think it's just about being honest and open with the information that you have, and showing all the information, I think, usually helps as well.
Yeah, not being cryptic.
Yeah.
Thank you. Okay, next question. How likely are new treatments for management or cure of PSC in the future?
So I think, well, there's quite a few clinical trials now, and some of them are looking at, well, they're all looking at different aspects. So there are studies looking to try and control itch. There are certain sort of trials which are trying to control sort of scarring. Some are trying to work on sort of bile acids. So they're all trying to work on different aspects of the condition, basically. I think if you go back 5 years, there were no clinical trials. So, I feel confident that with sort of the heavy investment from pharmaceutical industries, working with clinicians, working with patients as well and patient groups, there will be something. Now, like with anything, the first thing that comes along might be good, but there may be other better things. So I think we just need to watch that space. But for me as a clinician, it's great to say we have a clinical trial. Would you be interested? Because before it was, well, let's continue, let's monitor, and there was no therapeutic intervention. So I think in the next 5 to 10 years, there should be something which we can hopefully offer, which will have a positive impact on PSC as a disease.
That's amazing. I really counting the days for that one. And you've got how many clinical trials have you got at the moment at King's?
So one of them, the premise trial, has now closed to recruitment. I think we've got the NORSO study, the SPRING study, and the Pliant, and then there's an anti-itch one. So there's 3 to 4 that are running. And we've had a number of emails where patients have contacted us, I think, after sort of coming via the PSC support. We're very happy to then contact their clinical teams, get the information that we need, and then see what whether they're suitable from a inclusion exclusion sort of criteria. But we would never turn anybody away. Obviously there's screening and then they go through that sort of process, but we would always try and see if there's a trial for patients, definitely.
Fantastic. And we can help people get referred to King's to get on a trial if they think they're suitable. And on our website, we have quite high level eligibility, so whether you're suitable or not questions, so you can almost screen yourself to see if you may or may be on your way to being suitable. It's always a lot more complicated than we can think of ourselves, but once you do the high, do I need to have had a transplant or not, or can I go on the trial if I've got IBD, yes or no, and things like that, and they can you can maybe get on some. Okay, next question. Are there any dietary or homeopathic remedies like milk thistle, apple cider vinegar, turmeric, etc., that could make some difference?
So again, this comes up in clinic quite a lot. I think milk thistle, turmeric, they're all sort of antioxidants, and a lot of homeopathic sort of or natural therapies rely on them. And certainly growing up in an Indian Asian household, turmeric was thought to be the cure for everything. There probably is some benefit in there somewhere, but as a sort of science-orientated individual, I would say there's no hard evidence to say that it will truly benefit your liver. Things like milk thistle, they can interact with sometimes levels of certain medications. So you've got to be careful when you're taking it. It doesn't sort of, sort of potentiate or sort of suppress other drugs that you may or may not be on. So what I normally say is, if you're going to take a herbal remedy, make sure you know what's in it. Don't spend too much money, because a lot of the time I don't think there's much difference between going to Holland and Barrett's or Boots, but certainly don't buy stuff off the internet which you have no idea what's in it, because sometimes that can cause more harm than good. There's no substitute for a healthy lifestyle, a well-balanced diet, exercise, and just sort of trying to sort of moderate things. So I think individuals should be encouraged to sort of look at other options as well, but just know what you're taking.
Yeah, thank you. Is it correct that PSC presents differently in children and teenagers, and if so, why?
Very, very good question. I should probably get a pediatric colleague on there to answer that. I think the way that individuals can present is always very different. People can become jaundiced. People can present with itch. Some people can just present with actually inflammatory bowel disease, and when you look at the liver with blood tests and scans, there's evidence of PSC. There is a tendency sometimes in, I would say, children and young adults to have an autoimmune hepatitis sort of overlap. So that is the only obvious sort of difference that I would make, but it can be very subtle sometimes, and I think you just need to have an open mind. If the individual has one autoimmune condition, think about second or third, which unfortunately means if you have one, you are more likely to have a second or a third autoimmune condition. But they're probably the main sort of differences. But in the same way, if you find PSC, always look for inflammatory bowel disease as well, because it can be subclinical and patients may have very subtle symptoms. Until you look for it, you'll never find it.
Yeah, thank you. That's why we have to have a colonoscopy when we're diagnosed. I don't think every hospital is doing that still.
Right.
So hopefully one day we can get everybody following the guidelines. Okay, the next question is on IBD still, and essentially it's about whether PSC IBD is different to IBD without PSC, and what do we know about that and the interaction between PSC and IBD?
So I think my viewpoint might be quite biased because obviously I'm a hepatologist and I look after patients with PSC who then might have IBD. I don't look after patients with IBD alone anymore. So I think the comment I would make is that one of the things, again, we really work closely with our gastroenterology colleagues with either at King's or external centres, is that patients with PSC IBD have really good control of their IBD, because there is certainly sort of potential data to suggest that if your IBD is not controlled, then you're more likely to have this sort of these inflammatory cells which are absorbed by the bloodstream, which sort of feed the gut, which then goes to the liver, and then they can affect the liver. So we always sort of want excellent control. And again, there's a number of medications now, sort of infusions, which there's a ladder stepwise up where patients' IBD can be controlled. So I think that's really important. You could argue that anybody with IBD, they need good control, but I just really think in PSC IBD, it's key.
Thank you. So it is. Do you think it is a separate disease for just colitis or Crohn's alone?
Yeah, I think because the other aspect is because the liver blood tests may be a little bit deranged. There may be certain implications or reluctance sometimes of escalating therapy. So there's definitely a practical aspect to it. But yeah, I'm sure it is different as a phenotype. We've looked at our pediatric or sort of young adult service and how their IBD is managed, and again, good control of IBD impacts on overall sort of benefit for the patient, which is obviously is what we want.
Yeah. Thank you. Next question. I'm conscious of the time as well. We have 10 minutes left. Cholangiocarcinoma, hepatic dual stenting has been done, now diagnosed with cholangitis. Is there anything you would recommend to treat this, I suppose, hypothetically?
So if you've got bilateral stents, the key thing I'd want to know is what kind of stents they are. So if they are plastic stents, they can obviously block. Metal stents can block as well. So you need to sort of have a real good think about whether the stents don't build up a bit of sludge, or if it is in the context of cholangiocarcinoma, sometimes you can get tissue ingrowth into the stents as well, and in that case then you have to stent again through those stents. So it's about just making sure that there's good drainage, really.
So it's when there's not good drainage is when someone might get more susceptible to the cholangitis.
Yeah, it's a plumbing issue. I'm a very simple individual, so if the plumbing is blocked, then you have to unblock it.
Brilliant, thank you. Okay, this question is it's a little bit, so you can't give medical advice, but I'll just read the question out as it is. And then, so my recent blood test suggests my PSC is inactive. My next blood test is scheduled for July, but I'm getting pain and tiredness still. Is this usual? Is the blood test just a snapshot? And does the liver recover quickly? And how useful are these blood tests for monitoring?
So I think I said this earlier, I don't rely on the blood tests alone. I think it's about listening to the individual, what their symptoms are, how they've changed, repeating the scans, and sort of making you understand where their fibrosis as well. So it's not just blood tests alone. That's just one aspect of how I would assess an individual with PSC.
Thank you. We've got loads of questions here to get through. So there's a question about artificial bile ducts and whether they can be created or not. And they can, can't they?
Yeah, so there is sort of technology where bile ducts have been sort of grown. The bile ducts, obviously they're not just simple, when I said I'm a plumber, I think that doesn't do it justice.
Nobody
The
thinks
Bardics, the Bardics are so intricate. I always, when I talk about transplant to an individual and they say, well, my disease is in my bile ducts, why do I need a new liver? I sort of say the Bardics are like the threads of your shirt or your t-shirt. You change the whole thing. You can't just change a little bit. But there is sort of studies where they've grown sort of artificial bile ducts. But then the question is, how then do you implant it into the liver? Because obviously the cells, the bile duct cells at a microscopic level interact with the liver cells. There is some work in I think pigs where they've tried to inject into the bile ducts sort of therapies which are then applied to the area where you need it most in theory. So there is that aspect as well, which who knows whether that will be possible in humans. But yeah, we wait to see. I would say nothing is impossible, and we almost need to see what happens in the future.
And all the artificial bile duct research, it feels quite tangible and really exciting, and you can almost think of things that it could help with. So I'm really following that closely. It's really interesting. How would someone go about changing to King's if they wanted their care
there? So obviously speak to your current consultant. We sort of mentioned how the COVID pandemic has sort of impacted, and we've sort of got ways around that. But there's no two ways about it. At some point you'd have to come up to King's. If you live far away, you need to think about the logistics. But speak to your consultant. It's a very small group of individuals. Gastroenterology within the United Kingdom, and you can ask for your consultants. To refer, yourself to me. And like I said, I think if you live far away, having somebody local to look after you makes sense as well. Should there be sort of an urgent or an emergency or something, and then us at King's, we're there to sort of supervise any further treatment or involvement in clinical trials, or should you ever need it, liver transplantation.
Yeah, thank you. I mean, it's the ideal situation, isn't it, where you can stay local but get the expertise from somewhere like King's by the doctors themselves using a network. Can Dr. Joshi tell us what he considers to be the most exciting potential treatment for PSC that's currently in a trial or on the horizon?
Oh, wow. Well, the clinical trials, there's not been much data, to be honest, with the current trials that we've been involved with. Some of the the current studies at the moment, a lot of them are phase 3, where they're sort of big numbers and it's using either placebo or the active drug. But a lot of them have, in sort of phase 2 studies, have shown an improvement in alkaline phosphatase as a biomarker, which is not always the best biomarker sometimes in certain individuals, because in some patients their alkaline phosphatase is completely normal. So I think at the moment that is really hard for me to answer. Hopefully within the next, I'd say 18 months to 2 years, we should have some preliminary data, and then we'll understand where we're going. But just having options to help patients is great. So one of the studies we're running at the moment, the spring study, is a 12-week study. And once you finish that, you can then be eligible for another clinical trial. So if that works for you and it's feasible and the logistics aren't too complicated, then having that opportunity, I think, is great.
Yeah, that's quite a nice short one as well, isn't it? Compared to
12 weeks.
Yeah, excellent. Thank you. I've been told the sharp pain on the right rib cage is normal. Is there a specific type of pain we should look out for?
So I would say no pain is ever normal. I don't think we can ever say pain is normal. So when I talk to patients about their pain, I sort of ask them how it impacts them on a day-to-day basis. So if you can't do the things that you need to do on a day-to-day, then it's pretty severe. If it stops you from working, stops you from looking after your children, I think that needs to be investigated more. If it's ever associated with a temperature, a fever, then you've got to think of cholangitis. And it can be very subtle sometimes. So, it's all of these things. And if, the pain has been ongoing for a while, then, some repeat imaging, an MRI scan to look for gallstones, look at the gallbladder, make sure there's no evidence of infection there. I think, these are the steps that I would take.
Yeah, and not just ignore it and think, oh, everyone gets it, so I'll ignore it.
No,
look at
definitely
some,
not.
See what's going on. Thank you. Okay, someone's 17-year-old's just been put on the transplant list at King's. Good hospital to be at.
Very good hospital to be at.
So, well, we've got 1 minute left. One of them I can answer by email. What is the significance and seriousness of varices?
So varices are due to a sort of underlying condition called portal hypertension. And all that means is that the blood pressure, the pressure in the blood going into the liver is higher than normal. It occurs in all sort of, liver diseases. And essentially in chronic liver disease, your liver gets smaller, but that blood volume still needs to go sort of through the liver or get back to the heart. And what the body does, it creates these varices, these sort of new blood vessels, which then help sort of return the blood. And common places are in the gullet, in the esophagus, in the stomach, but really they can occur anywhere. But if you're told you have varices, then usually it means you have something called portal hypertension, which is high pressure in the blood system going into the liver.
Brilliant, thank you very much. And it's 2 o'clock, and I'm sorry we've not answered all of the questions. And I can, one of them I think we can leave definitely till next time, which is why are there more men with PSC than women? It's an interesting one, and I'll email Robert with his question. But to you, Dr. Joshi, thank you very much for giving up your Saturday for us once again, and being so clear with all your answers to the questions, which were really brilliant today. Actually, look, quite a big variety. So really appreciate that, and we appreciate your time. So thank you very much. And thank you to everyone for asking questions, and we should see you all again on the next Ask the Expert. Okay, thanks everybody.
Bye.